Hi, good evening. My name is Kristen Page, and this is my presentation for coordinated care for Capella University, FlexPath for the 4050 class with Dr. Mims. So in this presentation, I really want to touch base on what exactly coordinated care is, the different types of coordinated care that you could potentially see in a healthcare setting, possible ethical concerns and hurdles to actually using the coordinated care model to take care of patients, and just patient outcomes and what you can expect from patient outcomes when using a comprehensive coordinated care plan. So I'm going to start off by defining what coordinated care is. So care coordination synchronizes the delivery of patients' health care from multiple providers and specialists. The goals of coordinated care are to improve health outcomes by ensuring that the care from different providers is not delivered alone in a bubble, and to help reduce healthcare costs by eliminating redundant tests and procedures. A great example of this that I saw in the research was perhaps not ordering blood work if a patient is being discharged or transferred to from one facility to another. If you have blood work that's done within the past 24 hours, say you needed a CBC or to look at hematocrit or BUN or creatinine, if you have that from 45 hours or less than 48 hours ago, and there haven't been significant clinical changes that would warrant additional blood work, ordering another blood test is costly and really it's ineffective. If you're not seeing those clinical changes within the patient, what's the point of ordering blood work to pretty much tell you the same thing? Similarly with diagnostics such as x-ray, if a patient comes in, day 2 after having an x-ray and they're saying, well, my foot still hurts, you're probably not going to x-ray again because you already have an x-ray of the bones. So again, that would be redundant. It would be, very costly and time consuming and consuming of resources that could be better utilized for other patients that actually need the testing. Successful care coordination requires several elements. This includes easy access to a range of healthcare services and providers, good communication and effective care plan transitions between providers. Communication is key. If you cannot effectively communicate the background and assessment data on your patient when speaking to other disciplines, this is very problematic. So communication is something that I would definitely recommend to focus on. A focus on total health care needs of the patient. For instance, you're paying attention to the medical needs of the patient, but additionally, you're also keeping in mind psychosocial and mental health and, possibly financial burdens if that is going to dissuade people from seeking care because they don't have the financial means to do so. Clear and simple information that patients can understand. In my writing, I always advocate for presenting educational material to patients that is conducive to their education level. You're not going to, speak in 3-word sentences to someone that has a master's degree. And conversely, you're not going to go to someone that has an 8th grade education and use nothing except for medical terminology, saying diaphoresis and tachycardia. These are words that are not going to make any sense to them at all. So you have to be very cognizant of what the education level is of your patient in order to make sure they're included in their healthcare and can add to the process. So there are a few different care models. One is the guided care model, and it's specially educated registered nurses are responsible for patients with multiple chronic conditions. The RN performs an initial assessment with the patient, works directly with primary care providers to develop a care plan, and coordinates specialty care with other providers to ensure that nothing is missed and that the plan is followed. In one study, guided care was shown to decrease the total healthcare costs by 11% with an average net annual savings of $1,364 per patient for health insurers. In another guided care study, Lahey Health in Massachusetts credits guided care with achieving a significant reduction in hospital readmissions. Because of the great urgent and emergency nature of some patient situations, we're also looking at patients with acute health problems like a stroke or heart attack. and they require typically a more complicated degree of treatment. And because these medical crises, such as strokes and heart attacks, can occur at any time and at any location, individuals may seek treatment from emergency medical services and hospitals outside of their usual network. So a person that might live in a rural area that is having, a stroke might show up in the ER. They might show up in the ER dropped off by a family member, even though they don't drive. And then you have to keep in mind that this person lives in a rural area, might have significant psychosocial and financial barriers to the care plan. So that's something that needs to be addressed. When several physicians are engaged, the danger of communication failures, redundancies, and medical mistakes increases, making it even more critical that the health be synchronized and coordinated to obtain the greatest clinical results. According to studies, emphasis on communication between provider handoffs is a crucial component for success in acute care coordination. When the emergency has passed and the patient has been discharged from the hospital, acute care coordination continues. Follow-up visits are scheduled, prescriptions were filled at the patient's pharmacy, and follow-up instructions are reviewed with the patient and his or her family or loved ones by acute care coordinators. They'll also check in with patients a few days after they leave the hospital to see how they're doing and address any questions they may have. These efforts are aimed at lowering hospital readmission rates, avoiding unnecessary ER visits, and contributing to lower death rates. Another kind of patient that you might run into would be someone that resides in rehab or long-term care facility or a post-acute care facility and may need to move in between facilities or different care levels within the facilities as their health changes. An AHA study found that a majority of patients admitted to PAC are later transferred to a second PAC setting. These predominantly senior-age patients often have mental and memory disorders in addition to physical ones, and that creates, yet again, another barrier because you can't have the patient, taking part in their care if they're not of sound mind. They therefore require coordinated care to manage medications, transfers, and update care plans. The importance of this is increasing as studies show that hospital discharges to post-acute care facilities have increased rapidly, and hospital readmission from PAC facilities in common and associated with a higher mortality rate. Readmission risk factors may signify inadequate transitional care processes or mismatch between patient needs and PAC resources. At this point in my presentation, I would like to talk about community resources and possible ethical concerns just related to coordinated care. So there are a substantial amount of community resources for coordinated care. This includes food banks for proper nutrition, government programs that assist in affordable internet, housing, and childcare, local nonprofit organizations that assist with job placement, mental health care, including crisis centers that could potentially help someone experiencing a mental health crisis. In my research, I also, came across different websites that really focus on specific disease processes and specific interventions for the diseases. For instance, the American Diabetic Association has a lot of great resources with managing blood glucose. If you have a heart attack, you can look at the American Heart Association. That's an excellent provider to consider for someone that has heart and health issues. And these sorts of websites kind of compile all of the available resources, which according to my research, some of the primary care physicians aren't aware of. So I think as nurses, we do have a duty to kind of advocate for our patients and to make sure that the physicians, that are helping with care plans or helping with coordinated care are aware of these, particular services that can help out down the line. There are also a variety of ethical concerns regarding patient care. This includes respecting the patient's autonomy when making decisions, such as, deciding course of treatment. Someone that might be having a new diagnosis of cancer, being cognizant of the psychosocial concerns and the possible cultural barriers that may impede treatment. There are certain religions that, do not believe in stem cells. There's certain religions that, don't believe in blood transfusions. These are all valid ethical concerns because you don't want to dissuade someone from following their faith, but you also want to promote beneficence and do good for the patient. So it is kind of an ethical concern, is where do you draw the line? Healthcare workers walk a fine line pertaining to professionalism. You always want to advocate for your patients and do as much as humanly possible. However, you also need to maintain your distance and consistently show restraint as to not overstep your bounds. If you have a patient that's in severe need and you reach out and try to give them the resources, that's wonderful, and even following up is wonderful. And I highly encourage nurses to follow up on these particular patients that require a high degree of care. On the other hand, you need to remember that this is a profession and you need to remain professional. This is not family. These are not friends. These are patients. So again, there's that ethical concern that perhaps you might be operating not in your scope of practice, or, overstepping your bounds by trying to help these patients too much and therefore making them too dependent on you, and then they're not fending for themselves. So again, you want to adhere to the beneficence, but you also want to make sure that these patients are making the decisions, utilizing their autonomy, but making the decisions that are going to be best for their health in the long run. One particular issue that I wanted to touch on with coordinated care was the practice of medicine in rural areas. Often patients residing in these rural areas don't have access to phone, internet, or reliable transportation. They typically end up showing up in emergency departments or primary care offices when something goes terribly wrong. And getting the patients to follow up with their care after discharge remains, a big issue. If patients can't access internet services, then they won't be able to participate in telehealth. And additionally, without reliable transportation, medical care may be delayed and lead to disastrous consequences. If someone delays getting a blood clot treated, it could break off and go to their brain. I mean, if someone has a headache and they're not sure what it is and it turns out to be an aneurysm and they don't get, treatment for it, or stroke, or any of these number of very disastrous medical conditions, there are these significant barriers that we have to overcome. So again, kind of referring back to my resources, if you have patients like this that don't have the resources to, be active in their care, you as a nurse need to advocate for your patient, and you need to make sure that you're giving them the proper tools to succeed and to maintain their health. So in conclusion, coordinated care is an intensive and integrative process spanning multiple disciplines. Nurses are the frontline defenders of the coordinated care process, and by utilizing the nursing processes and maintaining professionalism coupled with beneficence, nurses can really ensure that patients are receiving top-notch care. And that is my presentation, and I really hope you enjoyed it.